Welcome to a presentation on dementia, professional and ethical dilemma of a case. I'm Dr. Prospero. I'm specialty doctor in older adult psychiatry. The outline of the presentation will be on the background and reason for the referral of this patient, history of presentation, 2 incidents, place and GMC comments, and past psychiatric history, past medical history, and current social situation, premorbid personality, activities of daily living, mental state examination, diagnosis and summary, management plan and recommendations and discussions, GMC guidance on driving and dementia. The background is for anonymity, patient BB, 68-year-old man, married for 25 years with no children. The reason for referral is this patient BB was assaulted and was very stressful and very angry with his staff and unfit to work, and referred for urgent mental health help to prevent post-traumatic stress disorder. The history of presenting complaints. Incident number 1. BB, the patient, reported 2 recent incidents which were the triggers of his low mood for the past 3 to 4 weeks. A lady who had a skin tags on her chin came to the clinic, and BB recommended to remove the skin tag at the surgery under local anesthesia. The lady declined and instead requested to be referred to a consultant dermatologist. The patient partner took photo of BB, and he also was reported to have made threats and charged him of allegedly assaulting the woman. The effect of this incident was later on to be narrated. The second incident, a week later, a 30-year-old girl patient came with a cough, and the patient's mother, the 13-year-old girl's mother, requested for dipro-based treatment for eczema and also oral contraceptive for the 13-year-old, and also Ventolin inhaler, which had been dispensed a month ago. BB declined all the requests, and the mother of the patient threatened to leave the surgery. Later, a noise was heard at the reception of the surgery. A man was sitting there very agitated. In the argument that followed, the man punched BB on the neck and kicked him in the left leg. BB fell down, and whilst lying on the floor, he reported that he was shaking and was unconscious. The police came in because patient's mother called the police, and the police alleged that BB was reported to have allegedly assaulted the man. He denied assaults, and he reported he had bruises all over his body. He was off sick for about 3 weeks. The patient's mother then reported to the GMC, alleging that BB had assaulted her partner. He was reported to have flashbacks and crying all the time. and self-blaming and feeling guilty and frightened to go out, with thoughts that the man might attack him. The effect of the incident was that he was having neck pain, irregular heartbeats, pain in the chest for which he was planning to go for an ECG, headache and imbalance, and now his wife has to drive him to work. He's able to come to the surgery for the interview and consultation, which was in the same room of the assault. The effect of the incident was that he was not wanting to meet anyone and felt on edge and unable to relax, and he could not remember details of the incident. He also had low confidence and he felt humiliated, but he had no suicidal plan or intent. Past psychiatric history: he has been in the past on venlafaxine, and he has had 3 car accidents in 1 year with whiplash injuries. He felt low mood in the past and avoidance with driving in the past. He was diagnosed with post-traumatic stress disorder in the past. In 2007, he had 2 similar car accidents. It was slow traffic or stationary, and his car was hit from the back. This made him avoid driving for some time as he lost his confidence in decision making, even in his day-to-day life, and he avoided meetings at the time. He's had a past psychiatric history of mixed depressive and anxiety disorder, and he was on citalopram and also had psychology assessment for cognitive behavior therapy for low confidence and avoidance. He experienced some side effects of citalopram, and his sleep was more disturbed and jaw clenching. So this was changed to sertraline, another antidepressant. He was reported to did not attend clinic appointment in 2009. He had psychology assessment and he was found to have memory impairment, as he forgets colleagues' names, also appointments, and GMC notes and plans. A cognitive assessment, that's the Addenbrooke Cognitive Examination ACE-R score of 80 over 100, and he was referred to the memory clinic for further assessment. Depression had no improvement, and sertraline was changed to metazapine, initially 15 milligram and increased to 30. He did not attend clinic in January 2010, and metazapine was increased in the same year to 45 milligram. He had neuropsychological reports of a depressive state and beginning of an organic factor such as frontotemporal dementia or semantic dementia. He was discharged from psychology to have a repeat test after 1 year and was to continue clinic with CT brain. Fitness to work. In 2010, he was referred to the memory clinic to assess whether he was fit to work. He had 3 sessions a week as a GP. An MRI brain showed atrophy in the medial temporal lobe. There was no evidence of white matter hyperintensity indicating vascular disease. He had a diagnosis of mild cognitive disorder and mild mixed anxiety and depressive disorder, and hospital anxiety depression scale score of 14 in anxiety and 15 in depression, both indicating significant symptoms. And the Stackstein Apathy Scale, he scored 27, more than 9 is abnormal. Frontal Assessment Battery Test, 14 out of 18. The higher the score, the better. And he had a 27/30 score on the mini mental state examination. The Addenbrooke Cognitive Examination revised ACE-R score of 83. Approximately a year ago, he scored 88. And the Silly Sentences test for semantic processing, he only made 1 error. He told the names of 2 doctors whose cases were currently being heard at the GMC, and he was probably not able to realize that this was not professionally appropriate, and he was referred for further neuropsychometric tests. In October 2010, there was a concern, so he was referred to Memory Clinic for opinion of fitness to work as GP, as mentioned, and but he did not attend DNA neuropsychiatry assessment, and the clinic raised concern about fitness to practice, and a letter was sent to his GP. He was advised to give up work and driving in November 2010. Duloxetine was the option discussed, but due to side effects of hypertension and the fact that he had only 1 kidney, mirtazapine was considered safer. Further neuropsychology tests were done in 2011, and more likely underlying neuropsychopathology was discussed, and he was recommended to be reassessed in 12 months' time. A dual referral was made. Hillingdon Neurology referred him to Charing Cross Neurology, while he was still open to the Memory Clinic in Hillingdon. There was no clarification of that. In 2011, he was discharged from the Memory Clinic for non-attendance and multiple on non-attendance. Advice was repeated in 2011 regarding concern that he was still driving without informing DVLA, and he has also not informed the GMC, and not heeding advice in the previous year by another psychiatrist. So he was advised not to drive and not to work. In 2012, he was discharged from clinic following multiple non-attendance. Past medical history: he has had myxedema, left nephrectomy due to adenocarcinoma, hypertension, cervical spondylosis, non-insulin diabetes, ocular hypertension, angioplasty, acute MI, acute painful diabetic neuropathy, motor vehicle traffic accidents. He was on mirtazapine, clopidogrel, levothyroxine, and other medications as listed. There was no family history of mental illness. He was born in Asia, trained as a doctor in the army, achieved 2 medals during the war with India, and came to UK and trained to be a surgeon. His current social situation: is married. His wife is caring and supportive. He's a practicing GP surgeon, self-employed, no financial debts, no forensic history. Premorbid personality, good at making decisions and involved in charity work. Activities of daily living, he's independent in all activities of daily living. Mental state examination, he was Asian man, alert and well groomed, no abnormal movements, speech was normal, his mood was low, 1 out of 10. Low energy, loss of interest in seeing patients, poor concentration, low appetite, no weight loss, no suicide intent or harm to others, no psychotic symptoms. His MOCA, which is the Montreal Cognitive Assessment score, was 21 out of 30, which was low. The normal is 26 out of 30 and above. He had good insights, and there was a question mark as to his concordance to medication. At this stage, one will pause to ask what the diagnosis is. This is summary of actions. The diagnosis of moderate to severe depression with no psychotic features, no suicide intent, anxiety of humiliation, and the consequence of appearing before a GMC panel. And he has some symptoms of PTSD, but not sufficient for a diagnosis of PTSD, post-traumatic stress disorder. He had flashbacks. He did not have flashbacks and being on edge. Though he currently had flashbacks and being on edge, he, however, did not have avoidance. The management plan was Medical Protection Society, which he was going to contact. Also, unsafe driving was discussed. He was on metazapine 45 milligram at night, and also supportive counseling. Lorazepam 1 milligram when required for agitation, and Zopiclone 7.5 milligram at night to replace diazepam. He was to be reviewed, and during the review, after 2 weeks, he had mild to minimal symptoms of depression, mood improvement while off antidepressant for 2 weeks, and he had coped well. Alzheimer's dementia was considered. He had no plans to restart active cholinesterase inhibitor. Neurologist consultation for Alzheimer's dementia. In the past, he was advised to contact DVLA and also advised independent driving assessment if he wishes to continue driving. And there was no evidence that he has informed the DVLA, and he retired from work in 2010. However, he continues to work. It was not clear about his fitness to continue working in line with GMC guidelines. Current issues of concern about his driving and fitness to work. Further management. He was discharged from the CMHT, and he was not on antidepressants, and he was told he must inform the DVLA of the diagnosis of Alzheimer's disease, and he was expected to inform the GMC within 4 weeks and to have a phone response from the patient. This phone response from the patient shows he was reluctant to follow the recommendations, so the CMHT informed GMC. The GMC Guidance on Conduct and Performance of Colleagues states you must protect patients from risk of harm. The safety of patients must come first at all times. If you have management responsibilities, follow the guidance in management for doctors. Driving and dementia. Can a person with dementia still drive? A diagnosis of dementia is not in itself necessarily a reason to stop driving. What matters is whether or not the individual is still able to drive safely. Patient must fulfill certain legal requirements, like telling the driver and vehicle licensing agency DVLA of their diagnosis. To drive, a person needs to be able to do the following: make sense of and respond to everything, maintain attention, anticipate and react quickly, take appropriate action, example, braking, steering, plan and remember where they are going. What if someone is unsure of their ability to drive? There's a driving assessment by independent approved mobility centers for a fee. Giving up driving, one must return their license to DVLA. Continuing to drive, patient needs to inform DVLA or the person's doctor will advise to stop driving immediately, at least until further assessments are carried out and reviewed. This medical advice should be followed. Driving and mild cognitive impairment. Notify DVLA only if their condition affects their ability to drive. The person's doctor or family members are good judges of this. If concerned, then DVLA needs to be told. Thank you.